Hi there, my name is Joan and I'm an instructor with the ACCN program. This presentation is part 3 of 3 review presentations for Module 5. In this last presentation we will focus on the determinants of cardiac output. Thinking back to your pathophysiology of the cardiovascular system, you will recall that cardiac output can be described by this equation. Cardiac output equals heart rate times stroke volume. Cardiac output is measured in liters per minute and is literally the amount of blood that is ejected from the heart in 1 minute. Cardiac output is influenced directly by the heart rate, which is measured in beats per minute, and stroke volume, which is measured in mils and is the amount of blood ejected from the left ventricle with each beat. I think this is intuitive. If you increase your heart rate, all other factors remaining the same, you will increase your cardiac output. And if you increase the volume of blood ejected per beat, then again, all other factors remaining the same, you will increase your cardiac output. Where things get a little muddy is the factors that influence the stroke volume. So let's take a look at these factors. Preload, contractility, and finally afterload. These are key concepts to understanding how the sympathetic nervous system stimulation affects cardiac output, and we're going to talk about each one of these in turn. Preload is the amount of stretch on myocardial muscle fibers at end diastole and is determined by the volume of blood within the ventricles at that time. Preload reflects the patient's fluid status and can be indirectly measured by central venous pressure for the right side of the heart and pulmonary capillary wedge pressure for the left side of the heart. Factors that affect preload: heart rate. A decrease in heart rate increases the amount of time for filling during diastole, so it can increase your preload, whereas an increased heart rate will actually decrease the amount of blood volume at end diastole. The actual blood volume that the patient has, if they're hypovolemic or if they're fluid overloaded, will influence your preload. Distribution of the blood, so if you have a patient who is septic where blood is moving or fluid is moving from the vascular space to the interstitial space, that decreases the amount of blood coming back to the heart. Atrial kick, in the case of a patient with atrial fibrillation, there is less blood moving from the atria to the ventricle. That last little contraction pushes a little extra blood into the ventricle. So if that's missing, then you're going to have a decrease in your preload. And then compliance of the ventricle, its ability to relax fully. The ejection fraction is a way we can measure what the preload is. It looks at how much blood is left in the ventricle after contraction. Normally, the ejection fraction is about 65%. To assess preload clinically, we look at the JVD for the right side of the heart, so looking to see if it's distended or if it's flat, and crackles or evidence of crackles or pulmonary edema for the left side of the heart. Let's look at the effect of certain drugs or interventions on preload. If your preload is too high, for example, your patient is fluid overloaded, so your CVP is elevated and your wedge pressure is elevated, you would see something like this maybe in heart failure or acute kidney injury. We can give a diuretic such as furosemide, which will increase urine output and decrease the circulating volume. Alternatively, we could give a vasodilator such as nitroglycerin, which would cause vasodilation and reduce the blood return to the heart. On the other hand, if your preload is too low, for example of this would be a patient who's had a trauma and is hypovolemic, or a patient with septic shock, where your wedge pressure and CVP would be lower. We can try to increase the preload by giving some crystalloid solutions like normal saline or Ringer's lactate, or colloid solutions such as RBCs and albumin. Contractility is an inotropic state of the myocardium, which is the intrinsic ability of the heart to contract independently of preload and afterload. Factors that will increase or give a positive inotropic stimulation are catecholamines such as epinephrine and norepinephrine, or inotropic drugs such as dopamine, dobutamine, and milrinone. Factors that will negatively affect the inotropic stimulation are acidemia, hypoxemia, myocardial disease, electrolyte disturbances, and drugs that actually have a negative inotropic effect, so beta blockers, calcium channel blockers. So contractility can also be influenced by medications and interventions. You might wonder why we would want to decrease contractility. In what situations? Normally, of course, we want to increase cardiac output. But contraction of the ventricle increases oxygen and energy consumption of the heart and can increase the risk of ischemia, especially in patients with that are post-MI. So medications that we can give to reduce contractility are calcium channel blockers, such as diltiazem, and it basically is used to decrease the concentration of calcium within the cardiac cell, which reduces the contraction. Another medication would be a beta blocker, such as metoprolol, which blocks the beta-1 receptors, so we decrease contractility that way. In order to increase contractility, so for example, if you're with a patient with that's in cardiogenic shock, we may want to actually increase that contractility. So medications that will have a positive inotropic effect are dobutamine, milrinone, and dopamine. In this cases, they stimulate the beta-1 receptor, increasing the amount of calcium levels within the cell, and that's how they have their effect for dobutamine and dopamine. Milrinone, on the other hand, works via a different method. It actually increases the amounts of cyclic AMP, which increase calcium levels within the cell. Afterload is the force opposing ventricular ejection. It's the resistance, impedance, or pressure that the ventricle has to overcome in order to get the blood volume out of the ventricle. It can be, as with preload, it can be indirectly measured, both for the left and the right side of the heart. We typically will use a PA catheter in order to get this measurement, although we don't use those nearly as much clinically, but that is one way to do it. It's the left side of the heart. You can measure afterload with looking at systemic vascular resistance, and for the right side, afterload is measured with pulmonary vascular resistance. Clinical indicators of afterload are a little more challenging to assess and are measured by looking for evidence or lack of evidence of organ and tissue perfusion. So with a patient with a high afterload, you would expect to see cold, mottled skin, decreased urine output, and a faint to absent peripheral pulses. On the other hand, a patient with a low afterload, you would expect to see flushed, warm skin, bounding pulses, and normal to increased urine output. Factors that affect afterload. With increased afterload, you've got peripheral vascular constriction, hypertension, pulmonary or aortic stenosis, so the actual vessel is stenosed, so there's no sort of compliance there. Vasoconstriction in response to stress or via vasopressor being given, and then body mass. Decreases in afterload are caused by peripheral vasodilation, so medications, a patient who is in a hyperdynamic sepsis where they've got massive vasodilation related to the systemic inflammatory response, neurogenic shock, those are all times when you'll see decrease in your afterload. With respect to the systemic vascular resistant regulation, it's regulated locally via autoregulation. So the tissue will respond to metabolic changes in oxygen and carbon dioxide levels. So increased carbon dioxide levels would cause vasodilation in order to improve blood flow to that area and get oxygen there. It's also controlled sort of globally by the sympathetic nervous system, which responds to changing BP. So if there's a decrease in cardiac output, then it will be stimulated. If the temperature increases, we'll see dilation. Blood volume, and the kidney also responds to low blood pressure via stimulation of renin and that activation system. Afterload can also be influenced by different medications and interventions. If the afterload is too high, we can use an arterial vasodilator such as nitroglycerin, or phentolamine, which is an alpha-1 and alpha-2 blocker. Another medication is calcium channel blocker diltiazem, and then an ACE inhibitor such as captopril. All of these medications cause vasodilation and therefore will reduce afterload. Another mechanism we can use to reduce afterload, which we don't teach in this program because it is typically only found in specialty ICUs such as a cardiovascular ICU, is a intra-aortic balloon pump. The intra-aortic balloon pump works by creating a bit of a vacuum, so it is placed in the aortic arch, and the balloon inflates during diastole, which pushes blood back into the ventricle, increasing the amount of fluid there and helping to perfuse the coronary arteries. Then the balloon deflates during systole, which helps pull that blood forward, and in that way it can actually decrease afterload and improve cardiac output. If the afterload is too low, we would want to use a vasopressor. Now, depending on the situation, what's going on with the patient, we may want to give some fluid first if the patient is hypovolemic, but strictly speaking, to increase your afterload, you would want a vasopressor, such as norepinephrine, phenylephrine, or epinephrine. And those are just a few options. Heart rate is probably one of the quickest and most effective ways to alter cardiac output. Normal rates are between 60 and 160, or normal rates where this will increase or decrease cardiac output are between 50 and 160 beats per minute. As rates fall below or above the normal rate, the factors that affect stroke volume come into effect. So a high heart rate, so we're talking greater than 160 beats per minute, there's decreased filling time. So we get decreased preload. And then as well, we're also getting a decreased contractility because of the increased workload of the heart. When your heart rate is low, so less than 50 beats per minute, you may see an increase in filling time, so increasing your preload, but there may be insufficient frequency of the beats to maintain an adequate cardiac output. With respect to heart rate, if the heart rate is too high, there may be some medications that can be given to lower it. This is typically mediated through lowering the calcium levels within the cardiac cells. So a calcium channel blocker such as diltiazem would be effective as it decreases intercellular calcium. And a beta blocker such as metoprolol would also be effective in reducing the heart rate. If the heart rate is too low, then catecholamines such as isoproterenol, epinephrine, and dopamine would be effective. Another medication that works through a different mechanism is atropine. Atropine blocks the parasympathetic system, which, as you will recall, is basically the opposite of the sympathetic system. So blocking that actually increases the heart rate. There are times when drugs are ineffective in increasing the heart rate and a mechanical or electrical solution is required. This is where pacemakers can be set to maintain a specific heart rate in an emergency situation until a more permanent solution can be found. So that concludes the last presentation in the review presentations for Module 5. I'm just going to really quickly review what we've talked about so far in this summary. We looked at some key definitions with respect to adrenergic receptors and activation. We looked at the autonomic nervous system, focusing specifically on the sympathetic nervous system, which is the fight or flight, allows you to respond to certain stressors. We looked individually at each of the receptors within the adrenergic within the sympathetic nervous system. So we looked at alpha 1 and 2, beta 1 and 2, and dopaminergic 1 and 2, and discussed what their particular effects were, where they were found in the body, and then finally we looked at pulling all that together and looked at how that affected our cardiac output and the determinants of cardiac output. So our preload, afterload, contractility with respect to the stroke volume, and our heart rate. These presentations were meant to be a review of information that you've had from other courses and just help to get that background for when you go into the module looking at catecholamines, inotropes, vasopressors, and vasodilators, to kind of get you that ground level information in case you'd forgotten some of that stuff. So I hope that was helpful. If you have any questions about any of the material in here, please contact your instructor.